So now we're going to talk about brainstem syndromes. As with the stroke syndrome talk, we are going to try to correlate the clinical anatomy with the symptoms and signs of these syndromes. So again, a little case. A 68-year-old male presents with altered mental status, vomiting and headaches. On examination, he has a right third nerve palsy, left hemiparesis, and right-sided loss of pain and temperature sensation. There's also left-sided ataxia. So just a few things here to point out what we look for with brainstem syndromes. First thing, syndromes with mixed laterality. So you have some things on right side and some things on the left side. Also, things that seem to affect cranial nerves as well as long tracts. Bearing in mind that the nuclei of the cranial nerves are in the brainstem. And finally, or other brainstem symptoms such as vomiting, altered mental state, and ataxia. Let's just have an overview of the brainstem. It's divided into three parts: the midbrain, pons, and medulla. It's worth remembering which cranial nerves lie where. So in the brainstem we have cranial nerves 3 and 4, and then we need to think about the long tracts that live in the brainstem. Well, of course, the pyramids and corticopontine tracts pass through the brainstem ventrally, and dorsally we have the medial lemniscus and the spinothalamic tract. Some important brainstem nuclei that are situated in the brainstem include the red nucleus and the substantia nigra. You'll remember the substantia nigra is very important in fine motor control and is affected in patients with Parkinson's disease. The pons carries the nuclei of cranial nerves 5, 6, 7, and 8. Ventrally, the pyramidal and corticopontine tracts pass, while dorsally we have the medial lemniscus, the spinothalamic tract, and the spinocerebellar tract. Bearing in mind that the peduncles of the cerebellum arise from the pons. The auditory tracts also lie in the pons. And finally, the medulla, which carries the nuclei of cranial nerves 9 to 12, ventrally run the pyramids and corticopontine tracts, and dorsally the medial lemniscus, the spinothalamic, and the spinocerebellar tracts. And the superior and inferior olivary nuclei lie in the brainstem as well. So the pyramids, medial lemnisci, and spinothalamic tracts cross over in the spinal cord, which would be below the brainstem, and therefore symptoms affecting these tracts will be contralateral because they cross over after they pass through the brainstem, whereas pain and temperature sensation do not cross over, and therefore symptoms affecting these tracts will be ipsilateral. So let's look at some brainstem syndromes. We have a picture here of a cross-section of the brainstem, and we're just going to look at a few syndromes. The first is Weber, or the ventromedial syndrome. This syndrome is associated with oculomotor palsy, that's third nerve palsy, contralateral hemiplegia, because the long tracts are affected, and as we said, they cross over in the spinal cord, and rigidity, possibly because of involvement of the substantia nigra. Secondly, we have Benedict, or the paramedian syndrome. The area infarction is shown in yellow, so dorsal and paramedian, and this can occur because of obstruction of branches of the posterior communicating artery. You get oculomotor palsy and contralateral hemiataxia, incoordination, and chorea, partly because of the involvement of the red nucleus and partly because of involvement of some of the long tracts involving position sense and motor function. Then the dorsomedial or clawed syndrome due to obstruction of the perforating branches of the posterior communicating artery. So the green area. Again, we get oculomotor palsy. So you can see a theme here. The oculomotor nerve is often affected on the same side in brainstem syndromes. Contralateral cerebellar ataxia and ipsilateral incoordination because of the involvement of the red nucleus. So the red nucleus is important in coordination. Finally, there are some other syndromes that are not necessarily stroke related, involving the dorsal midbrain or the superior cerebellar peduncle. So let's move on to the pons. Lateral pontine syndrome, associated with obstruction of the perforating branches of the basilar or anterior inferior communicating artery, affects the long tracts and therefore can produce hemiplegia and sensory loss. As we said, the pain fibers do not cross over, so you get ipsilateral loss of pain and temperature sensation, particularly to the face. The seventh nerve may be affected, seventh nerve nucleus, so you get facial weakness, and then hearing loss because the eighth nerve nucleus can be affected, but also ataxia, vertigo, and nystagmus because the cerebellar peduncles might be affected. Then we have the inferior median pontine syndrome due to obstruction of the paramedian branches of the basilar artery. The yellow area giving us contralateral hemiplegia because of the involvement of the long tracts, contralateral hemisensory loss for the same reason, ipsilateral facial weakness because of the involvement of the nucleus of the seventh nerve, and a conjugate nerve palsy as well. The ventral pontine syndrome due to obstruction of the basilar artery causes infarction of the entire ventral part of the cord and produces locked-in syndrome. The patient is quadriplegic with bilateral facial palsy and inability to speak. However, vertical gaze and eye opening is spared. These patients are conscious but unable to move and express themselves. And then you do have other syndromes involving the pons, such as the ventral pontine syndromes. Let's move on finally to the medulla. The lateral medullary syndrome is probably the most important of the brainstem syndromes in terms of your exam. It involves occlusion of the posterior inferior cerebellar artery. The patient presents with vertigo, falling to one side, and ipsilateral Horner's syndrome because of the effect on the sympathetic tract going to the eye and face. Contralateral loss of pain and temperature sensation. Dysphonia, dysphagia, and dysarthria because of the involvement of cranial nerves 9, 10, and 12, and also a decreased gag reflex because, of course, the involvement of cranial nerves 9 and 10. The medial medullary syndrome, due to obstruction of the perforating branches of the vertebral or basilar artery and affecting the area outlined in yellow, will produce contralateral hemiplegia and hemisensory loss because of involvement of the long tracts, and dysarthria because of involvement of the 12th nerve nucleus. And finally, hemimedullary syndrome, due to occlusion of the intracranial portion of the vertebral artery. One entire side of the medulla is affected, and so you get a combination of what went before: Horner's syndrome, 12th nerve palsy, facial sensory loss, cerebellar signs, and contralateral hemiplegia and hemisensory loss. So that was a quick look at brainstem syndromes. As I said, probably the most important for you to know is the posterior inferior cerebellar artery syndrome, or Wallenberg syndrome. But you should be able to correlate the others with the structures in each level of the brainstem to some extent. If you have any questions, you can ask them in class. Thank you for listening.